Hello, psychology students. This is Dr. Jeremiah Riordon, professional educator, doctor of education, master of education in psychology, and your professor of psychology for this semester. And the topic of this lecture will be methods of therapy. We will be covering the two learning modules listed on the screen, and you all know what you should be looking and listening for throughout this video lecture. So let's get going with the lecture. Your first password character is the number 6. Number 6. Psychotherapy helps people better understand and resolve their emotional or behavioral problems, often referred to as talk therapy. There are many different types. The most widely used therapies derive from major psychological models of abnormal behavior. Most forms focus on the individual, but other approaches include group, family, and couple therapy. There are a variety of helping professions in the field of mental health. Psychologists who provide psychotherapy may have degrees in clinical or counseling psychology, specializing in the diagnosis and treatment of psychological disorders and everyday behavioral problems. Psychologists generally hold a PhD in psychology and receive appropriate training in evaluating and treating mental disorders using psychological forms of treatment such as psychotherapy. Psychiatrists are medical doctors who specialize in the diagnosis and treatment of psychological disorders. Psychiatrists can practice psychotherapy and are able to prescribe drugs, although some psychologists are lobbying for prescription rights as well, given appropriate training. At present, 3 states in the United States, Louisiana, New Mexico, and Illinois, all permit specially trained psychologists to prescribe psychiatric drugs. Clinical social workers generally have a master's degree and are increasingly providing a wide range of therapeutic services as independent practitioners. Psychiatric nurses may hold a bachelor's or a master's degree and often play a large role in hospital inpatient treatment. And counselors are usually found working in schools, colleges, and assorted human service agencies. They typically have a master's degree and often specialize in specific areas, such as vocational or marital counseling. Psychodynamic therapy involves verbal interactions to enhance clients' self-knowledge or insight into their internal conflicts in order to promote healthful changes in personality and behavior. The original insight therapy was psychoanalysis, which was devised over 100 years ago by Sigmund Freud. To appreciate the logic of psychoanalysis, we have to look at Freud's thinking about the roots of mental disorders. He mostly treated anxiety-dominated disturbances that were then called neuroses. The overriding goal of treatment was to help clients gain insight into the unconscious roots of their problems, which Freud believed would free the ego from the need to defend against awareness of troubling unconscious conflicts. Freud theorized that people depend on defense mechanisms to avoid the anxiety that would emerge from conscious awareness of intrapsychic, which means within the mind, intrapsychic conflicts between the id, the ego, and superego. But Freud asserted that defenses tend to be only partially successful, leaving neurotic individuals troubled by psychological symptoms such as anxiety, guilt, fears, and obsessions. In psychoanalysis, the analyst attempts to probe the depths of the unconscious to discover the unresolved conflicts causing the client's neurotic behavior. To accomplish these goals, the therapist generally uses 4 therapeutic techniques: free association, dream analysis, interpretation of resistance, and interpretation of transference. In free association, clients spontaneously express their thoughts and feelings exactly as they occur, with as little censorship as possible, regardless of how trivial, silly, or embarrassing their thoughts might be. The analyst studies these free associations for clues about what is going on in the client's unconscious. In dream analysis, clients are asked to describe their dreams. The therapist then analyzes the symbolism in these dreams to interpret their underlying meaning. The client reports the manifest content of the dream, and the analyst's job is to interpret the latent content. Resistance refers to largely unconscious defensive maneuvers intended to hinder the progress of therapy. Clients exhibit resistance because they are unable to face painful, disturbing conflicts that they have buried in their unconscious. The analyst must manage resistance very carefully. Transference occurs when clients relate to their therapists in ways that mimic critical relationships in their lives. Thus, a client might start relating to a therapist as if the therapist were an overprotective mother or passive spouse. Interpreting the transference, psychoanalysts help clients gain insight into earlier conflicted relationships and see how these relationship patterns get played out in the context of therapy and their significant relationship with others. These reenactments bring repressed material and conflicts to the surface, allowing the client to work through them with the support of the analyst. Countertransference is basically when the therapist begins acting toward the client in a way that mirrors other important relationships in his or her personal life. Using a humanistic perspective, Carl Rogers developed a form of humanistic therapy called client-centered therapy, also called person-centered therapy, in the 1940s and 1950s. Client-centered therapy emphasizes development of a supportive emotional climate for clients to explore their true feelings and come to accept themselves for who they are, rather than continuing to wear the social masks and don the facades that conform to the expectations of others. The client plays the major role in determining the pace and direction of therapy. According to Rogers' theory, incongruence makes people feel threatened when they become aware of feelings they have that are inconsistent with their scrubbed but unrealistic self-image. Awareness of these discrepant parts of the self lead to recurrent anxiety. This anxiety often spawns defensive behavior intended to protect one's inaccurate self-concept. Hence, client-centered therapists try to help clients restructure their self-concept to better accept their true selves, warts and all, through a gentle method of reflecting back the person's own feelings. Rogers held that there are three main elements to creating this atmosphere: genuineness, or the therapist being completely honest and spontaneous with the client, as well as unconditional positive regard, which is a complete, non-judgmental acceptance of the client as a person. And third, with empathy, the accurate understanding of the client's feelings. Another form of humanistic therapy is Gestalt therapy, which is more directive than Rogers' client-centered approach. Developed by Frederick Fritz Perls, the emphasis is on helping clients to blend the positive parts of their life with the scary or threatening parts that they may wish to avoid. The here and now is emphasized, as is expressing and experiencing feelings. Role-playing and the empty chair technique are used with this approach to therapy. And your next character password is the number moving about the screen at this time. Behavior therapists focus on changing the problem behavior by applying techniques based on principles of learning. The underlying assumption is that psychological problems are largely learned and thus can be unlearned by applying principles of learning. There are many learning-based approaches used by behavior therapists to help people unlearn problem behaviors, like phobic responses, allowing the patient to acquire more adaptive behaviors, as through modeling, gradual exposure, and use of operant conditioning. Many behavior therapists take a broader approach called cognitive behavioral therapy, or CBT, that includes cognitive techniques modeled after the work of Aaron Beck and Albert Ellis, among others, in addition to learning-based behavior to change strategies. Your next password character is the number 1. Number 1. Behavior therapy is based on the principles of learning and conditioning. Behavior therapists use principles drawn from classical conditioning, operant conditioning, and observational learning to help clients change their problem behaviors and develop more adaptive behaviors. The original behavior therapy technique, systematic desensitization, was devised by Joseph Volpe in 1958. Systematic desensitization is used to reduce phobic responses. Gradual exposure is also used, where people are exposed in real-life circumstances just a bit at a time to increasingly fearful stimuli. In this video, we will watch a demonstration of exposure therapy that helps a snake phobic overcome her severe phobic reaction in just 3 hours. Learn what researchers have to say about this very brief form of treatment and how well the results are maintained over time. Modeling has been found effective where one observes others acting in appropriate manners and can then replicate those actions. This can be useful for things like social skills training, as well as overcoming phobias. In virtual reality therapy, a person with a phobia can be exposed to the trigger of their fear in a simulated environment. It is particularly useful for phobias that are extremely threatening or dangerous, or those that are very difficult to arrange actual exposure to. For example, simulated airplane takeoffs. We will now watch the video about the woman overcoming her severe phobic reaction to snakes.
Developed during the first half of the 20th century, behavior therapy is based on three types of paradigms: operant conditioning, classical conditioning, and modeling. Originally viewed as a scientific, reductionistic, and mostly sterile approach to counseling, today's behavior therapist realizes the importance of having a strong therapeutic relationship. For instance, it is now usual for the modern-day therapist to use empathy and develop a collaborative working relationship with the client. This allows the therapist to build trust and correctly identify targeted behaviors the client would like to change. After behaviors are identified, goals can be established and techniques chosen. Today's behavior therapists usually have a wide range of techniques to choose from, with some of the more popular ones being modeling, such as when clients observe behaviors, usually in the clinical setting, and later practice the behaviors in the office and on their own. Assertiveness training has been particularly used in this fashion. Operant conditioning techniques, such as positively reinforcing targeted behaviors and extinguishing unwanted behaviors, such as the use of sticker charts for children. Relaxation exercises, such as learning how to progressively relax oneself in an effort to reduce anxiety or other unwanted feelings. Systematic desensitization, which is often used with anxiety disorders, is the deliberate pairing of collaboratively chosen hierarchical aspects of the feared object with learned relaxation techniques, thus slowly reducing the fear response. Flooding and implosion techniques both involve the exposure to intensive amounts of fearful stimuli, with the assumption being that prolonged exposure will extinguish the fear response. And self-management techniques, which are used when one wants to help clients learn various behavioral techniques and have them practice on their own. In the following role play, Dr. Susan Thompson works with Rainier, who is struggling with a panic disorder resulting from a recent car accident. Dr. Thompson will assist Rainier in applying relaxation techniques to her anxiety about driving.
Hi Rainier, welcome back.
Hi, Susan. How are you?
I'm doing okay. So how has the practicing been going with the relaxation techniques that we talked about last time?
Well, it was kind of hard at first. I just kept having my heart palpitations and the sweating. And then I put little hearts up around the house. And every time I saw a heart, it helped me remember to do the breathing you taught me.
What a great idea, sort of that association.
Well, I really needed it because if I didn't see something outside of me, I just kept being involved in the feeling.
Right, right. And so that reminded you to bring up that relaxation that we talked about. Okay. Well, so one of the things that we're going to do today is to talk about the different components of what's happened for you, and use the relaxation along with sort of a hierarchy of events or situations that you might face. And eventually what we'll do is have you practice the relaxation along with each of the different pieces of it. Does that make sense?
It does. And that'll be good because it's been really hard just getting in the passenger side of the car. And somebody else has had to drive me.
Yeah, I was wondering about that.
And just getting in the car, it makes me very nervous, and I start to sweat and tremble and feel a little shortness of breath. And I'm real concerned that I won't be able to go back to work, and because I drive for a living. If I'm not driving, then I can't make do for my family.
So we really kind of have some short-term, immediate kinds of things that you want to focus on, getting in the car even, and then maybe some longer term that would be getting you back to work. Is that?
Yes.
Okay. You said that you had some of the anxiety came up when you were even getting into the passenger side coming here.
Yes.
Okay.
Yeah, I felt a little like I was choking, and I just had this loss of control that if I was in the car again, something else would happen.
Yeah.
And when this accident happened, I didn't have any passengers, and I keep thinking if it happened again, or what if there were passengers and somebody else was injured.
Right.
So it's very scary.
Yeah, it sounds like it was. Well, if we had to kind of break things down, because that's what you're telling me now of what's going on now, and if we had to break things down into smaller pieces, let's look at what those pieces might be.
Okay.
And I'm going to write some things down so that
Sure.
we can kind of keep things straight. So one of the things that you're having a hard time with is that even getting into the passenger side. But maybe we can back up from there.
Okay.
So as you think about even getting into a car, what happens to your anxiety?
It goes up. It's
Okay.
I'd say just thinking about getting in the car, it goes up to, on a scale of 1 to 10, it goes to like a 5.
Okay.
And maybe a 4. It's like it gets to a 5 when I get ready to get in the car.
Okay.
But I start the heart palpitations, and I'm sweating, and I start to tremble a little bit, and I just have that fear that I'm going to lose control or something's going to happen.
Yeah. So even just that's that thinking about it. And I'm glad that you went ahead and put that scale to it. We talked about that last time as a application here. So thinking about getting into the car is about a 4 or 5, depending on.
Well, probably is. I just get to me, it's not just thinking about you get in the car.
Right.
So I guess thinking about it is a 3, but actually
Okay.
getting in the car is probably a 5.
And is that getting into the passenger side or the driver's side?
Well, I'm getting into the passenger side. I've been too afraid to get into the passenger side.
Okay.
So the passenger side is definitely a 5, and the driver's side is higher.
Okay. So where would you rate the getting into the driver's side?
It's definitely at least a 7.
Okay. And I'm wondering if there's something in between there, getting into the driver's side, or what's surrounding that?
Opening the door.
Okay.
And once I got into the driver's side, and then usually then I kind of put my hands on the wheel and sometimes then I start the car after I check the mirrors and put on my seatbelt and stuff.
Okay. All right. So you're doing a great job of starting to break things down. That's exactly where we're headed with this. So just so that I have it straight, it's thinking about getting into the car even before you go anywhere, even before you leave the house, is about a 3. So that brings up some of the anxiety. And then getting into the passenger side is a little bit higher. Opening the door to the driver's side is a little bit higher than that, but not as high as, say, getting into the driver's side.
Right.
Okay. And then putting your hands on the wheel kind of brings it up a little bit more. And then starting the car is a little bit more too.
Yes, it feels like it would be. I haven't tried it yet because I've been too anxious about it.
And that makes sense. Okay, so starting the car, and then if we take it one step further, what would be another step from there?
I guess maybe driving the car like a short distance, or
yeah,
maybe
really
in the
short
driveway
distance.
or something.
A really short distance. So in the driveway.
Work.
Okay. And then what would be a next step from there that we could aim for?
I guess going around the block.
Okay. All right. And if you had to thinking about that right now,
that feels like it's a 9.
Okay. Okay.
Yeah, I'd start sweating all over again just thinking about driving and going around the block, because I know there'll be other cars out there, and that really is scary for me.
And I see that in your face. Okay. So then we have sort of a hierarchy of different pieces of getting back to driving that we can then apply the relaxation techniques. Okay? So let's just do one right now, just for practice, and see how that goes.
Okay.
Right? That first one that you have on the list is just thinking about getting into a vehicle.
Okay.
So right now, as you're thinking about getting into a vehicle, I see that you're kind of shaking. Remember the relaxation. Talk me through the relaxation that you're aware of.
Trying to take a deep breath and holding it for the count of 5, and then breathing out again.
Okay. So you're going to do that. Good. Just independently. Just be in that relaxed place. Great. And now, as you're in that relaxed place, think about leaving your house and getting into a vehicle, passenger side. And go back to that relaxed, take a deep breath, and go back to that relaxed place. And how is that?
Well, it's, the thinking about getting in the car is kind of scary, but I know I could put a heart in the car. I have hearts on the car, so I know to breathe when I see them, like I have them in the house.
Great idea. Great idea. So even right now, as you think about getting into a car, you can where would that heart be?
I would right now need to put it on the door.
Right on the door.
Or the window. Mm-hmm.
Okay. I almost thought of putting it big huge heart on the car.
Well,
but it's your image, so.
I have to feel better with a little one.
Okay.
Just a little one.
Okay, so let's go back to a deep breath, get to a relaxed place. Good. And as you're in that relaxed place, think about just going out to the car. The heart's right on the car, exactly where you put it. And keep relaxing. That's it. Go back to the
I feel more like I
place.
have to do it than I'm relaxed about it.
What do you mean?
Well, if I can't drive again, then I won't be able to work again.
We're just going to take it a little bit at a time. So right now, it's that one piece of thinking about going out there. The rest of it will fade away for right now.
Neat trick. Okay, that does feel a little better.
Okay. Before, when we first started talking about that, you rated it as a 3. Where is it right now?
It's probably a 2.5.
So we brought it down a little bit. What I'm gonna ask you to do then is to keep practicing that, because the more you practice it, just like you did at home, the more you practice the relaxation and with the heart, you were able to get to that place. It's the same thing with each one of these. So we're going to take it a little bit at a time, and we'll build from there. Okay?
Thank you. I appreciate your help.
Sure.
Virtual reality therapy, as mentioned before, is the use of computer-generated simulated virtual environments as therapeutic tools. The advantages are it offers some real-life exposure experiences that are difficult or impossible to arrange. The psychiatrist or psychologist has greater control over the stimulus environment. And also, individuals may be more willing to perform certain fearful tasks in a virtual reality setting.
We turn now to a surprising way to treat the psychological scars of battle. More than 30% of soldiers and Marines returning from deployments in Iraq and Afghanistan report psychological concerns. Many of them suffer from PTSD, post-traumatic stress disorder. Now, soldiers have always struggled with the memories of battle. Earlier generations might have used the term shell shock, soldier's heart to define similar symptoms. One of the defining symptoms of PTSD is the flashback, reliving the traumatic event. But what if doctors created a flashback to help soldiers heal? Would it work? ABC's Dan Harris reports.
Sergeant Brian Neal spent a harrowing and bloody year in Iraq. He survived dozens of IED attacks, including this one, captured on videotape by insurgents.
You got to be vigilant all the time because there's no warning, no nothing.
When Neal came home, he treated his post-traumatic stress disorder in what may seem like a supremely counterintuitive fashion by repeatedly reliving his worst memories in virtual reality.
The second you put it on, it's like you're back there again.
Does your heart race? Your palms get sweaty?
Yeah.
You're feeling anxious?
Yeah, you feel very anxious. You see helicopters flying over you, you hear gunshots, you hear the bomb go off, you're driving a Humvee, you hear radio, traffic in the background. It's exactly like being there.
During Neal's tour in Iraq with the Georgia National Guard, he was out on the road in a Humvee almost every day.
There's a constant state of stress and worry that, you know, if you don't do something right, or if you don't ensure that something is done right, or if you don't do everything that you can, someone will get seriously hurt or die.
On many occasions, Neal did see his buddies suffer and die. After a year of this, Neal came home to Atlanta, married his college sweetheart, and tried to resume some semblance of normal life.
It's amazing. You go through a year of what many people would describe as hell, and you come home and you're expected to fit right back in.
Right. And it's, like you said, it's very, very difficult to just jump right back into it. It's also hard to explain to people what you're feeling, especially when you don't understand it yourself.
He started having nightmares and flashbacks. When driving, he couldn't stop thinking about roadside bombs.
You know, I see a bag on the side of the road, and I swerve, and I've almost gotten in accidents where I swerved into either oncoming traffic or a lane near mine.
He was snapping at his wife, he says, and unable to concentrate at work.
When I knew that I needed to get help from someone.
Neal was diagnosed with post-traumatic stress disorder.
When somebody first proposed to you, we're going to put a helmet on your head and make you relive some of the worst things that have ever happened to you. Did you think, I don't want to do this?
Yes. I thought there was no way that I want to do this.
But psychologist Mary Rose Girardi gained Neil's trust. She's one of the researchers on a federally funded study on virtual reality and post-traumatic stress disorder. In this small room here at Emory University, she works with Iraq War veterans to digitally recreate their most horrible memories.
I asked him to show me under his arm, and I could see it was just covered in blood all down the side of his flak vest.
Here, Neil tells of struggling to find a way to get one of his wounded soldiers to safety.
What were you thinking going through?
I'm thinking that we're already beat up really bad, and we're already all stressed out, and I knew that if this is a bad part of town, if we got hit again, it could be really catastrophic for us.
Virtual reality therapy is a full-on sensory assault. Dr. Girardi put me inside the virtual war zone.
You can really get a view all over the place.
Yes.
The ground rumbles beneath your feet. They even pipe in diesel exhaust.
How are you doing with all that? Some of it is pretty loud.
It's pretty intense.
Dr. Girardi can make it day or night, desert or urban, depending on the trauma she's trying to recreate. In preparing this story, Dr. Girardi requested a reporter who had covered wars.
Firing! Firing!
I don't think this is a good thing, but I don't often get that scared. Because when you're out there as a reporter, you're thinking, I can't get hurt. I'm out here covering a story, I can't get hurt.
What might happen in terms of being a soldier there, where you do your job, your training kicks in, you figure out what you need to do. But then when you come home later, some of what you've been through hits you hard.
And when you do not process those memories, that is when they haunt you. And therein lies the power of virtual reality.
You're asking these men to go into the psychological heart of darkness.
It's frightening, but we believe it's worth it.
Here's how it works. When you have PTSD, you are constantly reliving horrible memories. But when those memories reach their peak, the most frightening moment, you cut it off. Virtual reality forces you to fight through the height of your fear so that you see that if you play the memory all the way out, you will survive.
By going through it there, it's not going through my head at night when I'm trying to sleep or when I'm with my wife.
Aversion therapy, a controversial form of behavior therapy used relatively infrequently, involves the pairing of an aversive stimulus with a target stimulus that elicits an undesirable response, for example, someone's craving for alcohol, so as to induce a conditioned aversive response to the target stimulus. People suffering from alcoholism, for example, have had emetic drugs paired with their favorite alcoholic drink, with the subsequent vomiting creating a conditioned aversion to alcohol. This technique has been used with alcohol and drug abuse, sexual deviance, smoking, shoplifting, gambling, stuttering, and overeating. One of the problems is extinction. Treatment effects may not last if the person engages in the undesirable behavior in their daily lives in the absence of any direct aversive consequences. When speaking about operant conditioning methods are mild forms of punishment or reinforcement that can alter behaviors. Examples might include using a timeout with children or a token economy in a mental treatment facility. Cognitive behavioral therapy incorporates behavioral and cognitive techniques in therapy. CBT therapists emphasize recognizing and changing negative thoughts and maladaptive behaviors, as well as problem behaviors. Albert Ellis developed Rational Emotive Behavior Therapy, REBT, which suggested that irrational or illogical thinking was at the heart of mental difficulties. The goal of therapy was to identify these tendencies and to replace them with appropriate thought processes. Students should review the ABC model, and later the D that was added, within the text. A major figure in cognitive therapy was Albert Ellis, covered in the last slide, who was the developer of Rational Emotive Behavior Therapy, REBT. Ellis emphasized how irrational beliefs lead to emotional problems. On the screen are some examples of these irrational beliefs. Irrational beliefs often take the form of self-demanding shoulds and musts. Students may wish to pause the video now and study these examples of irrational beliefs according to Ellis. And on the screen now is an example of Rational Emotive Behavior Therapy, REBT. Students may wish to pause the video now to review Maria managing anxiety with ABCs. Aaron Beck devised cognitive therapy to help clients change how they think. The process involves detecting and recognizing negative thoughts, reality testing, and performing behavioral homework assignments that focus on testing beliefs in light of evidence and changing overt behaviors. And on this image, note that nearly half of clinical psychologists surveyed identify with either a cognitive or behavioral orientation, whereas nearly 1 in 5 identify with a psychodynamic orientation. A collective, integrative therapy is also among the most widely endorsed theoretical orientations. These therapists draw upon principles and techniques from different therapeutic orientations. However, some therapists argue that therapeutic integration is neither desirable nor achievable. Group therapy involves the simultaneous treatment of several clients in a group setting. Group members work to assist each other in their treatment. The role of the therapist in group therapy includes screening potential participants, facilitating the therapeutic process, and preventing potentially harmful interactions. Group therapy is not just a less costly alternative to therapy. It has strengths of its own. Advantages include it is less costly, it helps with interpersonal problems and social skills, and it allows individuals to share coping strategies. Drawbacks include it is not one-on-one. Individuals may have a reluctance to disclose personal information, and participants may suffer from feelings of inhibition.
I think there's oftentimes a sense that cancer just separates you from the people that you love, all the life that's going on around you, and you're off to the side.
This is a demonstration of a peer discussion group, a support group for women with breast cancer. It's not psychotherapy, but there is a trained facilitator who encourages women to share their feelings.
What other things have you all noticed?
I lost all my hair. It's different. I'm not used to seeing myself. I don't necessarily recognize myself, and I notice that others don't recognize me.
Losing hair was hard for me too. The first time I noticed it was when I woke up one morning and it was just all over.
Peer discussion groups are available in many communities throughout the United States. The goal of such groups is to improve the women's quality of life. But do they? That's a question raised over a decade ago by Carnegie Mellon University psychology professor Vicki Helgeson, and her answer may surprise you. Helgeson decided to compare peer discussion with another form of intervention that is frequently used, education. As shown in this demonstration, education groups focus on information.
Tonight our topic is communication. We're going to be talking about a set of skills that really has relevance in all the relationships that you're conducting. Since you've been going through your breast cancer treatment, I know communication is
An education group is run like a classroom.
Before we get started, I'm wondering if anybody has any questions.
I've got a question. Is it okay?
Over 300 women were recruited for the study. They'd undergone surgery and chemotherapy, but all had good prognoses. Groups of women were randomly assigned to education, peer discussion, a combination of education and discussion, or a no-treatment control. The same coordinators worked with each group, and they met once per week for 8 weeks. How did these interventions affect quality of life?
Women who received education, which means they were in the education or the combined condition, had a better quality of life on really anything we could have measured. All kinds of indices of mental functioning and physical functioning.
And there were decreases in negative affect, anxiety, and depression. But some women benefited more from education than others.
But women who had low self-esteem, low body image, feelings of low control, low optimism, and a lack of support at home were even more likely to benefit from the education intervention.
And many benefits have lasted a period of years.
This shows the change in negative affect over 2 years. So you can see that the education condition is different from all 3 other conditions. In the education condition benefited initially, and it was maintained over time, whereas the other 3 conditions showed no change over time.
But how did women do in the peer discussion intervention?
We found no benefits at all for the peer discussion condition. And
Helgeson believed that the benefits of peer support might appear gradually.
But we followed women for 5 years now. We've seen no benefits of the peer discussion intervention.
Helgeson is not dismissing peer support groups. Perhaps with groups running longer than 8 weeks and with therapists rather than facilitators, different results might be obtained. But the appeal of this study is that it examined 2 interventions readily available in many communities, and the findings lead to a suggestion for healthcare providers.
Put your resources in developing an educational intervention.
Because for women with breast cancer, education is cost-effective, relatively easy to implement, and has resulted in some impressive quality of life findings.
Family therapists challenge the idea that problems in the family are owned by one particular family member. Family therapists take a broader view that examines how problem interactions are embedded within the family structure. Troubled families learn to communicate better and resolve their differences. The family, not the individual, is the unit of treatment. And individual problems are symptomatic of family system breakdown. Couple therapists or marital therapists work with members of a relationship and the couple, not any one individual, in the unit of treatment. Emphasis is normally on communication skills that can develop to help solve problems. Power struggles are also emphasized so that they can be reduced. And your next character password is the lowercase letter moving about the screen now. Remember, it is a lowercase letter. Evidence supporting the effectiveness of psychotherapy comes from several sources, including large-scale meta-analyses such as the classic Smith, Glass, and Miller study from 1980, shown here, as well as controlled studies pitting particular types of therapy against control groups or against each other in treating particular types of problems. Psychology, like other helping professions, is moving toward evidence-based practices. On the screen are some of the therapies found to be empirically supported in controlled research trials in treating particular problems. Students may wish to pause the video now and study the screen examples of empirically supported treatments. Therapists must be aware of and sensitive to differences in cultural traditions and beliefs of clients they treat. Issues such as negative treatment, histories of prejudice and discrimination, and culturally appropriate suspiciousness must be sensitively considered by a therapist. Your textbook gives examples of how culturally competent therapists integrate cultural factors in treating African Americans, Asian Americans, Hispanic Americans, and Native Americans. Therapists are obligated to examine their own cultural biases so that they do not negatively affect their clients. Module 14.2 Biomedical Therapies. Biomedical therapies are physiological interventions intended to reduce symptoms associated with psychological disorders. They assume that these disorders are caused, at least in part, by biological abnormalities. What are the advantages and disadvantages of psychiatric drugs? Though psychiatric drugs can help control symptoms, they are not a cure, nor do they teach patients how to resolve their problems or develop necessary life skills. They also carry risks of adverse side effects, and relapses are common when patients stop taking them. Sometimes, however, the combination of drug treatment and psychotherapy is better than either alternative alone. Electroconvulsive therapy, also known as ECT, is used as a treatment of last resort in cases of severe depression when other treatments have failed. And psychosurgery has all but faded due to serious complications and lack of effectiveness, although experimental treatments, including deep brain stimulation, are in the testing stage. Drugs used in the treatment of psychological disorders fall into three major groups, as seen on the screen: anti-anxiety drugs, antipsychotic drugs, and antidepressant drugs. Anti-anxiety drugs, such as Valium and Xanax, relieve tension, apprehension, and nervousness. Valium and similar drugs enhance the effects of GABA on receptor sites. The net result is that these drugs indirectly increase inhibitory activity in the GABA system, which helps keep a lid on overexcitation of the nervous system and induces feelings of calmness. Antidepressant drugs gradually elevate mood and help relieve depression. The most frequently prescribed antidepressants are selective serotonin reuptake inhibitors, SSRIs, which interfere with the reuptake of serotonin by the transmitting neuron. Antidepressant may be a misnomer, as these drugs can be used for a variety of other conditions, including bulimia nervosa, panic disorder, social phobia, PTSD, generalized anxiety disorder, and obsessive-compulsive disorder, among others. Antipsychotic drugs such as thorazine, Zyprexa, clozapine are used primarily in the treatment of schizophrenia. Antipsychotic drugs are used to control psychotic symptoms, including hallucinations and delusions. Antipsychotic drugs dampen activity of dopamine synapses. They appear to do so by binding to dopamine receptor sites, which suppresses or blocks dopamine activity at these sites. Overactivity of the dopamine system in the brain is linked to the development of schizophrenia. Newer generation antipsychotic drugs are favored now because they carry fewer neurological side effects. Lithium, a naturally occurring salt, is a commonly used mood stabilizer in the treatment of bipolar disorder. Lithium can help control manic episodes and stabilize mood swings. However, it can be toxic and requires careful monitoring. Stimulant drugs, such as Riordon and Concerta, have been used to treat the symptoms of ADHD in children, and seem to work by increasing dopamine levels in the frontal lobes of the cerebral cortex. Developed by Antonio Igaz Moniz in the 1930s, the prefrontal lobotomy was hailed as a miracle treatment for violent or aggressive tendencies in mentally ill patients. It was discontinued after horrendous results ensued, including some deaths. It also fell out of favor because of the development of psychotropic medications that were less risky and more effective. Deep brain stimulation is a more recent and less invasive form of psychosurgery that involves implantation of an electrode that provides electrical stimulation of specific brain areas of patients with severe obsessive-compulsive disorder. It is also being explored as a treatment for severe depression in cases in which less invasive treatments have not worked. Electroconvulsive therapy, or ECT, is a biomedical treatment in which electric shock is used to produce a cortical seizure accompanied by convulsions. Although the use of ECT peaked in the 1940s and 1950s, there has been a recent resurgence in this therapy. ECT is used today mainly as a treatment of last resort for seriously depressed or suicidal patients who have not responded to less invasive treatments, such as psychiatric drugs and therapy. The exact mechanism by which ECT works is not well understood, but it is associated with relapse in the weeks following treatment, as well as some memory loss symptoms. Deinstitutionalization refers to the movement away from inpatient treatment in mental hospitals toward more community-based treatments. Deplorable conditions in many mental hospitals fueled this movement in the 1960s and the 1970s, as did the ability to treat serious mental health problems with antipsychotic drugs. However, many people express concerns that deinstitutionalization has led to a surge in psychiatric homelessness, and that hospitals have become revolving doors that shuttle patients back and forth between the community and the facility without providing the necessary continuity of care. Applying psychology in daily life. How do we get help when we need help? One of the first steps to getting help when help is needed is choosing a therapist. To choose a therapist, individuals should seek recommendations from respected sources. Seek a referral from a local medical center or local community mental health center. Seek consultation with your college counseling center or health services center. Or contact professional organizations for recommendations. Students may opt to let their fingers or their computer mouse do the walking, but be careful. Make sure the treatment provider is a licensed member of a recognized mental health profession, such as psychology, medicine, counseling, or social work. Inquire about the type of therapy being provided, and inquire about the treatment provider's professional background. Students should also inquire whether the treatment provider has had experience treating other people with similar problems. Discuss the diagnosis and treatment plan before making any treatment commitments. Ask about costs and insurance coverage. Find out about the treatment provider's policies regarding charges for missed or canceled sessions. And if medication is to be prescribed, find out how long a delay is expected before it starts working. And if treatment recommendations don't sound right to you, discuss your concerns openly. If you still have doubts, request a second opinion. And be very wary of online therapy services. The uppercase letter on the screen now is the final password character. And that concludes this video lecture on the 2 learning objectives within the methods of therapy. Students should now have all 5 password characters. To my students, as always, I finish with a wish for you to have peace and to be well. Dr. Riordon, that's Riordon, done, and signing off.